Afternoon, everybody. So, I'm feeling a bit warm actually. I don't know about you, but I'm not sure the aircon's working here. So, Renovascular MRA. The brief history of renal MRA. It's one of the first applications that MRA in the body was really aimed at, and has a long and illustrious history, including people like Chuck DeMoulin here, who's really a grandfather of the MR Angio Society. And started out with things like phase contrast, and then moved on, as you do, through the era of 2D contrast-enhanced MRA and onto 3D contrast-enhanced MRA and time-resolved MRA. So what are we trying to do when we image the renal arteries? It's good to go back and look at what we get when we do invasive DSA. So this is an invasive DSA, and the thing I'd like to take away from this is the fact that the renal arteries normally come off the abdominal aorta around about here, but they can come off the iliac arteries down here. Okay, so if we're going to image the renal arteries, we need to be able to image the abdominal aorta from the diaphragmatic hiatus down into the iliac arteries. And if we're going into the iliac arteries, we may as well look at the iliac arteries out to the groins, because that's our access point if we're going to actually intervene upon any of these things. So what do we need to know? What kind of information do we want to gain from the images if we're going to do a renal MR angiography? So how about normal people? People like you and me. What do we want to know if we're imaging you and me? If we want to donate our kidney to a child, for instance, and we're going to have a renal MR angiogram, what kind of information do we need to get from it? Well, we need to know the renal morphology, size, shape, position, ureters, okay? We need to know if there's any pathology that we don't know about in this healthy-looking patient. Do they have incidental calculi, scarring, cysts and stuff? Do they have accessory arteries? And where are they? How many are they? We need to know the length of the renal arteries and whether they divide early or not. Do they have incidental atherosclerotic or fibromuscular disease? We also need to know about the veins. It's not just all about the arteries if we're going to donate a kidney. And we also would like to know differential function. We want to know something about whether one kidney is providing more function than another kidney. So there's actually quite a lot of things we need to know about normal people. And so if you're going to have a comprehensive protocol, we need to look at all the aspects of this, including just normal morphological imaging. We tend to use T2 fast spin echo type sequences, coronal or transverse, doesn't really matter which you use. And we can see nice corticomedullary differentiation on this. These look like nice healthy kidneys. And corticomedullary differentiation is shown to be a marker of nice normal healthy kidneys, as opposed to if we lose this corticomedullary differentiation, it's a sign of parenchymal disease. As I say, we need to know where the kidneys are. Someone in this room might have a kidney lurking down here in the pelvis and they don't even know about it, okay? Because the kidneys start down in the pelvis and migrate up the back of the abdomen, so they're not always where you expect them to be. So we need a large field of view that includes the pelvis. If we're going to look at renal size, we also want to look at renal size in a way that's reproducible with isotropic voxels that we can reformat in any plane. Okay, so we can reformat a 3D T1 in an arbitrary plane and therefore get the actual exact length, or potentially we can actually get a volume of the kidney if we have a seed growing algorithm where we've got this nice differentiation between retroperitoneal fat, which is dark, and the contrast enhanced kidney in this case. And in this instance, this patient has got a very long and funny kidney on the left side because they've got a multiple renal pelvis and a cross-diffused ectopia. So does renal size on MRI actually mean anything? Are we accurate with renal size on MRI? Well, here's some work that shows that we are quite accurate. This is in pigs. This was published back in JMRI back in 2002, where we took the size of kidneys on MRI from living pigs. The pigs were then sacrificed, and we took the kidneys out and we measured how big they were, and we got a very nice straight correlation. Can you do the same with humans? Well, this is a study we did in Glasgow. We measured the size of the kidneys. We sacrificed the volunteers and took the kidneys out. No, we didn't do that. What we did was, these were subjects who were donating kidneys for live renal donation. So we knew we were going to take the kidneys out of the body. So we segmented the kidneys. We used a Cyrix. We then took the kidneys out of the body, and then we used very high-tech equipment to measure the volume of the kidney. So here's the high-tech equipment we can afford in Glasgow. And we put the kidney into the high-tech equipment, and we measured how much fluid was displaced. So we therefore knew how big the kidney was, and compared that to the volume that we derived at MRI. And it was basically exactly the same. Give or take a few mils for bits of renal pelvis and fat and stuff hanging off, pretty good correlation. So we can prove that when we say a kidney is a certain size on MRI, then it really is that certain size. So if we see a tiddly-kiddly, like this one here, we know it really is a tiddly-kiddly. And if we see a funny kidney like this, which has got hasn't got normal corticomedullary differentiation, the alarm bells ring, and this actually turned out to be renal lymphoma, this one. We can also see other pathologies that we don't necessarily would see on CT because we've got superior contrast differentiation on MR. So this is a patient who's had a previous episode of acute tubular necrosis and has cortical scarring. How about non-contrast renal MRA? Well, initial days we use time of flight, but we get these kind of Venetian artifacts, and of course with the flow in the renal arteries is within the plane of the slab, so we don't really see that very well. Phase contrast, you usually get quite good pictures of normal renal arteries. It doesn't, in my experience, show abnormal renal arteries so well, and of course the field of view is relatively constrained. We can't see down into the iliac arteries. We can get beautiful pictures from non-contrast renal MRA. So this is the kind of thing that you put on the cover of JMRI. I think this was on the cover of JMRI, in fact. But this is a quote from a famous MR enthusiast here. Says that NC-MRA techniques are often complex, inefficient, and not standardized across vendors and poorly validated. And this, unfortunately, does remain true for non-contrast MRA of the renal arteries. So although these are available, and they do show very nice images usually in normal renal arteries, we find that they don't always work so well in pathological renal arteries. As opposed to contrast-enhanced MRA, which does seem to work well both in normal and abnormal renal arteries. So here's a nice normal subject with two renal arteries arising quite close together on the right side. And here's another one from another vendor. So between vendors we've got quite good correlation, and these all look the same. And here's another one from a different system again. Spatial resolution. I'm going to talk a little bit about spatial resolution. This is important in renal MRA. And it's what gave MRA, not only in renal but in all sorts of other spheres, sometimes a bad name. So this is a renal MRA, contrast enhanced, not the world's best example. And here's the corresponding DSA. And what we thought was a stump of a renal artery on here, in fact, is a penetrating atherosclerotic ulcer, and the renal artery is a tiddly little thing up here that the renal MRA did not resolve because it was very, very small. There's a catheter angiogram of that. And here's some examples from St Elsewhere, where they wondered why their renal MRA wasn't performing well compared to their DSA. This was two renal arteries they found on DSA, and they hadn't resolved that on the MRA. And the answer is the spatial resolution. The spatial resolution is just not there in the implementation that they've done. This was back in the early 2000s, so it's quite a long time ago now. But this is the kind of thing that gives renal MRA a bad name, is when you get fuzzy, indistinct images like this with poor spatial resolution that doesn't match up with when they put the catheter angiogram in. So what kind of spatial resolution do we need? We need really sub-millimeter, I would say. Sub-millimeter isotropic resolution is the ideal. But of course, as with all MR, we're competing time to acquire that spatial resolution versus the contrast passage through first pass. And in the renal arteries, then we have to do it in a breath hold, because the patient has to be holding their breath at the same time. Because if the renal arteries are moving up and down, as we'll see, then they really don't look quite so good. So breath holding, this is a really important part of renovascular MRA. The kidneys move with respiration, and so do their arteries. Okay, so this should be a movie. Hopefully, it'll work. Oh, no, it's not moving. Should go back. This should be a movie. For some reason, it's not working. But anyway, I'll demonstrate with my own arms. Okay, so imagine there's a kidney attached to each of my arms. If I breathe, the kidneys move up and down. The aorta in the middle doesn't move. The proximal renal arteries don't move so much, but the further out they are and the smaller they are, the more they move and the more we don't see them. Okay, and we end up with something like this, where we might see the proximal main trunks, but the kidneys are blurred and we don't see the intrarenal arteries. And that's because the patient has not held their breath for the time of the examination. And we can see this on the partition images here. And we can see the kidneys are fuzzy when we look at the partition images. So what we do is we bring the patient back, we coach them in the breath holding, and we get a much better examination when they come back and they properly hold their breath and the kidneys are nice and sharp and everything. Okay, and we can see the number of renal arteries, and we can reformat them in any plane, etc. And we can see accessory renal arteries. We can see them coming off down near the aortic bifurcation or even the iliac arteries down here. and we can also see the veins. And the veins are just as important if you're going to donate a kidney as the arteries. People fixate on the arteries, but in fact the veins are often what leads to the kidney ending up in the bucket. And one of my disasters, my own personal disaster in my practice, was an altruistic donor who, we said there was one renal artery on the right and it didn't have an early branch, and that was all fine, but we hadn't resolved the veins well enough. And what I hadn't seen on the MR was the fact that this customer had 6 renal veins on the right side. So when they took the kidney out, they ended up with lots of holes in big blue, and lots of patching up needed to do. The kidney went in the bucket, and the expected recipient, who'd also been put under anaesthetic, had been put under anaesthetic for no reason. So a real disaster all round because we hadn't looked at the veins. Not only the veins, but the ureters. If you've got 2 ureters, the transplant surgeon is not going to want to take out that kidney because that's 2 ureters they're going to have to anastomose to a bladder. There's 2 ureters that are very small and fiddly, and they're more likely to necrose or stenose, so they don't want to take a kidney that's got 2 ureters. So we need to look at not just the arteries, not just the veins, but also the ureters. So we need some comprehensive protocol that looks at all of these things in a good way. And here's a retroaortic renal vein. About 3% of us have a retroaortic renal vein like this. Sorry, it's more like 1% have a retroaortic vein. About 3% have a circumaortic vein, in which case we've still got a residual renal vein in front of the aorta as well as a component behind the aorta. And the more you look at the renal veins, the more variable you find that they actually are. This is a customer with unsuspected situs inversus. So this is again a renal donor we didn't suspect had situs inversus, where the cava is on the left side of the aorta. Again, that's something that the surgeons don't want to find unexpectedly when they go in to do their surgery. And if you have a comprehensive protocol, then what you end up with is what I would call a 21st century medical IVU, in that people will use this test if they have confidence in the test, then they will ask for the test. We tend to just use post-contrast IVUs rather. We did for a long time. We ran with non-contrast IVUs with the pineapple juice. With this, it's got manganese, which suppresses fluid in the bowel, so we don't see any duodenum and jejunum peristalsing over here. We get rid of all that with the pineapple juice, and obviously they're hydrated, so we get a good diuresis. But the patients, they didn't like a litre of pineapple juice, to be honest, and it was difficult to buy lots and lots of it. Someone thought we were hoarding it for Brexit, I don't know. So we now just use a post-GAD IVU with a tailored vibe sequence on our Siemens systems anyway, which gives us a nice IVU after in an excretory phase. And here's someone with another accessory renal artery. They're awful common. So here's a husband and wife team. They came, both were examined on the same afternoon because they wanted to donate to their child, and we could say which one of them was actually going to be useful for doing that. I did show this morning, but I'll make no apologies. So this is the first time resolved breath hold contrast enhanced MRA. This is me holding my breath for 40 seconds. And this was the first example of using sense to accelerate contrast enhanced MRA enough that we could actually do that. But this brings me on to perfusion. So if we're going to image contrast passage through the kidneys, through the vasculature of the kidneys, we may as well look at the contrast passage through the kidneys themselves. So again, something that we've incorporated into our protocol is we use MR Perfusion on all our patients, whether they be hypertensives or donors. We do an MR Perfusion examination, and we use that as our timing bolus because, as I say, we're very, very particular about breath holding, and we don't want to use any of the smart prep or bolus track or any of these things for the renal MRA, because invariably what happens is if you're using smart prep for renal MRA, there's all this noise going on, the gradients are slamming away while the contrast is going in, the patient's a bit panicky, he doesn't know whether he can hear the technologist doesn't know whether the patient can hear, the patient may be breathing out when the technologist says to breathe in, or they're breathing in when the technologist says to breathe out, and it's all a bit of a disaster. So we've moved away completely for the last 5-6 years from using bolus tracking for these, and we use our perfusion as a timing scan. We give just 1 mil of GAD with a saline chaser, and we know that the contrast is going to arrive at, say, 24 seconds, and then we can count that down, and there's no magnet noise going on, and the technologist can say, breathe in, breathe out, breathe in, breathe out, hold your breath, and there's no distractions from the gradient slamming away, and we get nice breath holds, and it becomes a reproducible test. I don't know whether my movies are going to work here. These are supposedly perfusion movies. For some reason, this is my Mac, and it's not showing the movies, but never mind. So we get several coronal slices and a transverse slice. This might be a movie, but then maybe it's not going to work. But you've seen perfusion MRA before.
It's actually working on the screen, even though you can't.
Oh, well, maybe I can't see it. Is it working on the screen?
Yeah.
Do-do-do.
You go back on the slide. There.
Do-do-do.
Click once it's working.
Yeah, yeah, you go. And you see them moving up and down as well. Okay, so there's a renal perfusion. I'll say we get the bolus arrival time from the transverse image. So at the moment, this is on our old system. This is a Siemens Avanto that's now 11 years old. So we get 3 coronal slices and a transverse slice per 1.5 seconds temporal resolution. We're currently working on translating that into a more modern system whereby we can get a whole renal volume, a 3D volume per time point. We then put this into a MATLAB derived sort of thing, which we do the GFR and blood flow and blood volume from, and we can get single kidney GFR. The good news I heard the other day just before I left Scotland is that we've got a DMSA shortage. So at the moment, a lot of these patients have been getting DMSA anyway, and they haven't really believed our MRI results, even though we've shown that they are the same. But with the DMSA shortage hitting, then hopefully we'll be able to just completely take over that part of the service. What about other techniques? Well, arterial spin labelling has been used, including in our group. We've got a group within Glasgow that's doing quite a bit of ASL for perfusion analysis, but it does very much remain in the research domain and has not yet migrated to clinical. How about for abnormal patients? I've talked about normals. So for abnormal patients, it's exactly the same. We want to know all of this stuff. Not so fussed about the venous variants. We also want to know probably a little about the adrenal glands. Luckily, the adrenal glands just sit right on top of the kidneys, so when we're doing the morphological imaging, we can see them anyway, and we can see whether there's adenomas or there are not adenomas there. This is something that shouldn't have, but did certainly hit the amount of renovascular imaging we did. This is the Astral trial, which is looking at revascularization versus medical therapy for renal artery stenosis. But what you have to remember about the Astral trial was you were only randomized into Astral if your clinician felt that your renal artery disease was in the grey zone and they didn't think that it would actually impact if you had it operated on or had an angioplasty or stent. So for patients in whom we thought really did need an angioplasty or a stent and we thought it would benefit them, they weren't actually eligible to go into Astral. So although Astral was a negative result in terms of it said that angioplasty and stent didn't help patients with atherosclerotic renovascular disease, that's because everyone that went into Astral were in this grey area where probably, they had a bit of 50-60% on one side, 40% on the other. They didn't have really stonkingly bad renal artery disease, and they certainly didn't have FMD. If you had FMD, you were not eligible to go into Astral, so you would not be randomized in Astral. So FMD, renal artery disease, we've seen a couple of instances of this today already. The question is, what is FMD? Those are obvious FMD that I just showed in that previous slide, but is this FMD? Is this corrugation here? Is that something that is really FMD, or is that just a standing wave from the renal artery being a bit in spasm when you inject contrast into it directly? I think this is a standing wave example. For example, I don't think that's FMD. This is FMD, okay? So this is a doctor who, when they were training as a medical student, had hypertension, and they had all the tests of the day as a medical student, including an IVU. And they said the IVU was normal, and therefore they didn't get further investigated. Well, the IVU probably was normal 30 years ago, but later on when we did a contrast-enhanced MRA, we thought, well, actually, this looks like FMD, and here's the correlative DSA of the same customer there. So FMD you can certainly see on MRI, as long as you've got decent spatial resolution, and by decent spatial resolution I mean 1 mm isotropic voxels or less. And of course, atherosclerotic renal artery stenosis, this is atherosclerotic renal artery stenosis that we didn't think was suitable for Astral, because they've got critically stenotic disease bilaterally. They've got a kidney that looks a good size on the left that's got decent T2 signal, but on the right they've got a very dry looking kidney. There's not enough blood getting in that, it doesn't look wet enough. So I went in, this is one of the last interventions I did. I gave up IR about 6-7 years ago now, maybe more, I don't know. But this is one that I did. This patient came with an unrecordable blood pressure into hospital. By unrecordable, it meant it's over 300 millimeters systolic, and these modern digital sfigs don't actually go above 300. They couldn't measure her blood pressure. So I took her to the lab, and she had bilateral renal artery stenosis. Because I'd done the MRA, I knew exactly what angle of dangle I needed for my C-arm in order to profile the renal artery ostia. and I banged in some renal artery stents, and her blood pressure came down on table. She said she had this, I feel very funny, doctor, and she had this kind of flushing sensation, and her blood pressure came right down. And it's been down ever since. She's still under follow-up under one of my clinical colleagues. So for our comprehensive renal MR angio, we do morphological imaging, we do some perfusion imaging, we do a contrast-enhanced MRA, we do an arterial, and then we do a sort of kind of early venous phase, just in case the first one's not quite right. We then do a T1 fat sat volume, and then we do a T1 MRU, and they're on and off the table in under 20 minutes. So renovascular imaging, I thought I'd just put this in at the end. Okay, this isn't the kidneys so much, but it is a patient who's got renal disease. This is a patient who's got an EGFR of 10 with end-stage renal failure. They're not on hemodialysis yet, but their brachiocephalic fistula has been formed and it's pulsatile, but it's not matured as expected. So why is that? And the reason is, if we look through this, is that there is something going on with the outflow from that fistula. So it's flashing past you very quickly there, but if I go back and I volume render this, you can see that there's a tight stenosis in the outflow for this fistula, and that's why the fistula is not maturing. So we can go and do an angioplasty. This is a centerline curved MPR, so we know exactly how far up these two tandem stenoses are up from where you might puncture, so we can put the angioplasty balloon up. And that was using ferromoxetol, obviously. So it is one of the advantages of ferromoxetol is that even my very sensitive physicians, who we had a lot of cases of NSF in Glasgow years ago because we used a lot of Omniscan, and we had quite a few cases, which we've had none since we stopped using Omniscan, but our renal physicians are still sensitive about giving gadolinium contrast to their renal dialysis patients. But they're quite happy for us to give them ferromoxetol because it's the kind of thing they would give them anyway for treatment. So in summary, we can assess all the critical aspects of donors, normal people and abnormal people, in both, and those who are hypertensive. And it's more than luminology. It's more than just looking at the blood vessels. Your protocols have to look at the other bits and pieces as well. Thank you very much.